Hey guys, let me ensure the stream is live.
My referral code that is doc.
Guys, let me ensure the stream is live. Okay, great. So we can begin. I'll just put this on my channel. So we are meeting after a long time here on YouTube. I had taken a session yesterday on the Unacademy platform where we had discussed MCQs for abdomen. So it was a very successful MCQ marathon. I also received a few texts regarding how much they liked that pattern. So thank you so much, guys, for participating in that. We're going to have more MCQ marathons. I'm going to have a MCQ marathon for abdomen again, and because we were not able to complete all the questions, so we'll have more MCQ marathons for abdomen, and then we'll do one for GI physiology, for which I had taken a plus course, so that can be covered. Welcome to Let's Crack NEET PG, the YouTube channel of Unacademy, the NEET PG division, where you have the top educators, quality content, and a great learning experience. My name is Chetanya Mittal. I'm an MBBS from All India Institute of Medical Sciences, that is AIMS, New Delhi. So we'll talk about breast and clavipectoral fascia. So what we're going to do here is, this is basically the first part that is there for the upper limb. This is the first thing that people usually study when it comes to upper limb. We start with the pectoralis major muscle usually, right? And we start with the humerus bone, and in viscera we go ahead with breast first, right? So we'll do breast and clavipectoral fascia. They're kind of related. And before I begin, I would request you all to go ahead and download the Unacademy learning app. All right, click install, go to the Play Store, click install, and when you do that, you will have to buy a free plan. To access all the free content, all you have to do is go ahead and click on free plan. Okay? And when you buy the free plan, you will have the option to enter a referral code. And when you enter the referral code that you have to enter is SPCM, or you can also enter another referral code, that is Chetanya 10. Alright, you have to enter any one of these two referral codes, Chetanya 10 or SPCM, right? And then you can unlock the free plan where you'll be able to access all the free content that is there for you on Unacademy, right? So that's what you have to do here. And my plus referral code is Chetanya 10, so that's the referral code that you have to use. So on Unacademy, you will find the top educators teaching for NEET PG, and you can see a lot of these are also from my institute, that is AIMS. So educators for NEET PG, we all are making plus courses for you guys. I've also made a plus course for GI physiology. Go ahead, have a look at it, do review it, do rate it well if you guys watch the plus course. And then there are special classes which are absolutely free of cost that are there on the platform, and I would ask you to watch these because they will give you a very complete summary of a particular topic. You can attempt mock tests. Right now there is NEET PG T20 grand mock test there on the Unacademy app. Go ahead, attempt it. And there's a comprehensive syllabus coverage, and you know why Unacademy is the easiest way to learn online, because as medicos, we have busy schedules. Unacademy gives you the flexibility and the option to revise whatever you're doing with notes that are provided as PDFs. So that's really great. And the Unacademy app has a very robust chat feature. Here also, I can interact with you guys live. All you have to do is just drop a comment in the live chat, and I will be able to reply to you. I have it opened on my mobile phone, and whenever we do MCQs, I try to do them as interactive polls, and you can learn anytime, anywhere you want. At the end of today's class, we'll also do a live quiz. And I'll host it for you on the Unacademy platform. All right. So about the subscriptions, there are two kinds of subscriptions: the Unacademy Plus and Unacademy Iconic. Unacademy Plus, you have all the live classes, live tests, live quizzes, batch courses, and a structured schedule. On Iconic, you not only get the best of Unacademy, but you also get the best of Prep Ladder. You have the video lectures, the question bank, the rapid revision course, and the handwritten notes that are there for Prep Ladder, right? And there are top faculties like GRG sir, who teaches for pharmacology, Apurv Mehra sir, who teaches for ortho, and these are faculty who are teaching for prep ladder, and you get all of that in the iconic subscription. I would recommend you go either with the 1 year or the 2 year plans. They cost 55,000 and 77,000 respectively. Apply my referral code, and the magical referral code, it gives you a 10% discount, right? It gives you a 10% discount straight away that is applicable on all kinds of subscriptions. It does not matter if you take a NEET PG subscription or a NEET UG subscription or an IIT subscription. Whatever subscription you take, use my referral code and take whatever plan you want to purchase. Then these are the subscriptions for Unacademy Plus. The 1 year subscription after referral code is less than 25,000, and for 2 year Unacademy Plus it is less than 40,000. So it's come down to 36,000 for you, right? And again, you have to use my referral code Chetanya10. You can join my Telegram channel, that is Unacademy NEET PG Chetanya, right? @ Unacademy NEET PG Chetanya, right? Chetanya is my name, and Unacademy NEET PG is the goal. Okay. So right, these are all the plans, and you can enter the referral code here. The referral code option is here. You enter the referral code Chetanya10, and if you have any credits by watching the free videos that you have unlocked using the free plan, just use these credits and click on apply. All right, you will apply. The referral code will get applied here, and these are the comparison of the iconic and the plus plans, right? So should we begin our today's class on pectoral region? So I have my handwritten notes for you guys for this particular class. Okay, give me 1 second, guys. Okay, great. The chat feature was not working here. Now you can see it again. So let's start with the pectoral region. First of all, whenever we talk about the pectoral region, we have to talk about the various surface landmarks that are there on the pectoral region. So the first and the most important surface landmark, which is also an MCQ for your NEET PG, is your nipple, right? It is one of the most important surface landmarks, and it's a very recognizable surface landmark. It's often asked that where is the nipple located? It is located in the fourth intercostal space. It is located in the fourth intercostal space, and this positioning is more constant or more uh, correct for men, right? Fourth intercostal space. The nipple is located where? The fourth intercostal space is the location of the nipple. Okay, be very careful. Just remember this. Then where is the nipple located? It's located medial to the mid-clavicular line. All right. Now, what is the mid-clavicular line? The mid-clavicular line is a line that runs from the middle of the clavicle. All right, passes through the tip of the ninth costal cartilage, and then it goes to the mid-inguinal region, right? So basically you have two things. You have a midpoint of your inguinal ligament and you have a mid-inguinal point. So it goes till the mid-inguinal point. So basically it starts from the middle of your clavicle, then on your rib tip of ninth costal cartilage and mid-inguinal point, right? So these are the three surface landmarks that will be covered by the mid-clavicular line. So the nipple is located medial to the mid-clavicular line. All right. So it is located. So if this is your, let's say this is your clavicle, this is the middle portion of the clavicle, and this is your mid-clavicular line. So the nipple is located medial to it, towards the midline. All right. That is what you have to remember about the location of the nipple. After that, you know what is your clavicle. Now, what is your jugular or your suprasternal notch? It's basically this palpable landmark that you can feel here, where you can basically put your hand and you will feel there is a depression there. It's called as the jugular or the suprasternal notch, very easily recognizable. And if you look at 5 centimeters below it, all right, if you come here 5 centimeters below it, you will feel there is a prominence. It's basically where your manubrium sternum is merged with the body of your sternum. There at this point, This is known as the sternal angle or the angle of Lewis. Alright, this is very, very important as a surface landmark. It marks the second costal cartilage and it is used to count the ribs. It is used to count the ribs, and I have told you a mnemonic in one of my previous series. The mnemonic is MAD, RAT, BP, to remember what are the structures that are at the level of the second costal cartilage, that is at the level of the vertebral level T4, T5. Okay, it corresponds to the what vertebral level? T4, T5. So I'll erase some of the ink. Let's take a different color. Alright. Now, what about next? Next is the epigastric fossa. The epigastric fossa is basically, if you touch the bilkul base of the sternum, there is a slight depression there that is known as the epigastric fossa, and it's at the level of the seventh costal cartilage. It's at the level of the seventh costal cartilage. Besides that, other surface landmarks, there's an infraclavicular fossa, right, which is also known as the deltopectoral triangle. Why? Because on the medial side, it is bounded by the pectoralis major. On the anterior side or the lateral side, you have the deltoid, and then you will also have the clavicle forming its base. Okay, and slightly lateral to it, you will have the coracoid process. Slightly lateral to it, you will have the coracoid process. Not very important. Okay. Axilla, it's again very important. Axilla, you have to know about these four folds: anterior fold of axilla, posterior fold of axilla, medial fold of axilla, and lateral fold of axilla. The anterior fold is formed by the lower border of P major. Posterior fold is formed by the tendon of latissimus dorsi winding around the muscle teres major. Medial border is by upper four ribs, which are covered by scalenus anterior, and the lateral border is by the short head of biceps or the coracobrachialis along the shaft of the humerus. Okay, so we'll just cover this. We have a diagram of the axilla, but anterior border, posterior border, medial border, lateral border. Anterior border is lower border of pectoralis major. Posterior border is latissimus dorsi and teres major. Medial border is your upper four ribs covered by the scalenus anterior, and the lateral border is the short head of biceps and coracobrachialis against the shaft of the humerus. Alright, so these are the four borders of or four folds of the axilla. We'll cover these in more detail as we move ahead. For now, these are what you have to remember regarding surface landmarks. I'll repeat what are the important points. The first most important point is regarding the nipple, fourth intercostal space and medial to mid-clavicular line. Second most important point here is the sternal angle, which is located 5 centimeters below the jugular notch. It is also called as the angle of Lewis. Structures at this level are MAD, RAT, BP. Okay, MAD, RAT, BP. And then the third important thing here is the axilla. It's four folds: anterior fold, posterior fold, medial fold, and lateral fold. We'll come to this again, don't worry. So one more thing, so we talked about the mid-clavicular line here. We talked about this is the mid-clavicular line here. Now there's another line known as the mid-axillary line, and it is located exactly between the anterior and posterior folds of the axilla. That is known as the mid-axillary line. So what are the various lines? This is the sternum, then you have the mid-clavicular line, and here you have the mid-axillary line. So these are the three vertical line marks or vertical lineations when you talk about your surface of your body, right? So this is the overview of the surface of the pectoral region, right? And now we'll go to the various structures that you will find when you come to the pectoral region. What is the superficial most layer? That's going to be your skin. That's going to be your skin. After that, we'll talk about the next thing, that is the superficial fascia. Now, when you come to the superficial fascia, there are a few things that you should know. First, what are the contents here in the superficial fascia? What are the contents of the superficial fascia of the pectoral region? The most important content here is going to be fat, right? Why? Because it's the most abundant content here in the pectoral region. There's lots of fat in this region. The second thing is glandular tissue, that is your breast. Fibro-fatty glandular. Fibro-fatty glandular. Please remember this for histology as well. Whenever we talk about the histology of breast, I'm going to keep repeating fibro-fatty glandular. That's the description of breast. And what's the description of prostate? The description of prostate is fibro-musculo-glandular. Alright? Because there you don't have as much fat when you talk about the prostate. And the third thing that we need to talk about is a subcutaneous muscle known as platysma. The third thing that is there in this particular pectoral region is platysma. It's present although in the cervical. It extends from the cervical region a little towards the down. So it's basically your muscle which is subcutaneous called as platysma. you flex your neck like this, it's the muscle that becomes prominent here. It's different from the sternocleidomastoid, please note. And then we talk about there are cutaneous nerves and there are cutaneous vessels. The cutaneous innervation is through the cervical plexus and the intercostal nerves, and the cutaneous vessels are coming from the internal thoracic and the posterior intercostals, right? The anterior part is supplied by the internal thoracic and the posterior part is supplied by the posterior intercostals. Now we'll talk a little bit about the muscle platysma. Platysma is a subcutaneous muscle. Can anybody tell me the nerve supply of platysma? What is the nerve supply of platysma? Please write your answer in the chat box. I have put the question in the chat also. Nerve supply of platysma. What is the motor nerve supply of platysma? You've studied this in your head and neck also. Motor nerve supply of platysma. Remember the facial branch, it forms a structure here. It divides into 5. So one of the branches of the facial nerve supplies the platysma, and which branch is that going to be? That is for you to tell me in the chat box. I am leaving that question to you. It is a subcutaneous muscle and its origin is also facial. It takes its origin over the deep fascia which is covering the pectoralis major, and it inserts onto the base of the mandible. It's covered by the skin over the most of its surface, and it also inserts into skin on the posterior lower face, right? So it basically inserts here. So that's a little bit about your platysma muscle. We have talked about the contents. Now we'll talk about the cutaneous nerves and vessels a little bit, and then we'll move on to breast. All right. So that's the main topic for today. The motor nerve supply of platysma, I haven't got any answer. The motor nerve supply of platysma is the cervical branch of facial nerve. The motor nerve supply is the cervical branch of the facial nerve. Mishti, very good. Cervical branch of the facial nerve is the nerve supply of platysma. Now, when you talk about the cutaneous nerves of the pectoral region, you will see that the dermatomes, if you look at the dermatomes, it's an abrupt transition from C4 to T2 here, right? So you know what are dermatomes? They are parts of skin supplied by a single spinal segment. They're the cutaneous innervation to a single through a single spinal nerve, right? So if I make this person here like this is the upper limb and this is the thorax, right? That's somewhat how the person is. So if you talk here, there's a very abrupt transition here from C4 to T2, right? Why? Because the rest of the dermatomes, C5 to T1, they will enter here into the upper limb. So there's an abrupt transition between C4 and T2 at the upper half of, at the level up till the second rib, right? Where you have the sternal angle, you have a very stark transition of the dermatomes. So the upper half of the deltoid here and the part from the clavicle to the second rib, that is supplied by the supraclavicular nerves and the cervical plexus. The supraclavicular nerves, there are 3: medial, intermediate and lateral. The intermediate supraclavicular nerve sometimes pierces the clavicle. It sometimes pierces the clavicle. That's a very important point that you study in clavicle, that the clavicle may be pierced by the intermediate supraclavicular nerves. Root value is C3, C4 and it comes from the cervical plexus, right? So that's about the supraclavicular nerves. They supply till the second rib, up till the second rib, clavicle to the second rib. The upper half of the deltoid is going to be supplied by these nerves. Then you have anterior cutaneous nerves and lateral cutaneous nerves that will supply the rest of the pectoral region. Anterior cutaneous nerves come from T2 to T6 and lateral cutaneous nerves come from T3 to T6. Then there is one very important nerve that you know about that supplies the floor of the axilla. So basically I said that the T2 dermatome, it is very sharply present here when you talk about the level of the axilla or the second rib. And there's a nerve that goes from here and it enters the floor of the axilla to supply some part of the floor of the axilla and upper half of the medial side of the arm. That is known as the intercostobrachial nerve. That is known as the intercostobrachial nerve because it is coming from the intercostals towards the arm. So intercostobrachial nerve, which is root value is T2. It is coming from T2. Alright. So that's about the cutaneous innervation. Cutaneous vessels, you don't need to know much. You need to know that there are perforating branches of internal thoracic artery. The important point is that the second, third and fourth perforating branches of internal thoracic artery, they are enlarged in females. They are enlarged in females. Now, why would they be enlarged? Because they have to supply the breast in females. So that is why they are going to be enlarged in case of females. And these are your cutaneous vessels, perforating branches of internal thoracic artery, right? Besides that, posterior intercostals give some lateral cutaneous nerves, which will also supply some of the lateral side and the posterior side of the pectoral region, a little towards the posterior side, towards the lateral side, right? Now we are going to start with breast, right? Are you ready to start with breast? Are you guys ready? Are you guys ready to start with breast? At 7:30 p.m. today, we have another class, and that class is for urea cycle and its disorders. Urea cycle and its disorders. So do attend that class. That is going to be very helpful for your biochemistry. Almost urea cycle is almost a very important topic from your protein metabolism or your amino acid metabolism. Okay, so do attend that class as well at 7:30 p.m. I will see you guys for that class also. So right now we're going to start talking about the breast. So the main things that you should know about the breast are the lymphatic drainage of the breast, the clinical anatomy of the breast. These two things are very important whenever you talk about the breast. Besides that, there is a blood supply, there are some relations that you have to know. But the main things that I want you to guys to know is the lymphatic drainage of the breast and the clinical anatomy of the breast. So I did a special class known as the A to Z clinical anatomy of the breast, where I covered 26 clinical anatomy points of the breast. That's more than enough for your breast. That also includes points from your surgery NEET PG. So don't worry, just go ahead and watch that class on Unacademy, and that should cover around your entire clinical anatomy of the breast. Right now, we'll talk about the blood supply. There are mainly uh, two sources where you're deriving your blood supply. There's also a third relatively minor source. First, we'll see that the breast is an anterior part and there is a posterior part. The posterior part is relatively vascular. The main supplies to the anterior part of the breast. Anteriorly, what is the artery that is running here along your thorax, right? What is the artery that is running here? That is the internal thoracic artery, which is a branch of the first part of the subclavian artery. Remember, the first part of the subclavian artery has three branches: VIT, vertebral, internal thoracic, and thyrocervical trunk. So, internal thoracic artery, it's coming from the subclavian artery, and it gives some mammary branches towards the medial side. Those are known as medial mammary branches. Medial mammary branches because they are coming towards the medial side of the breast, right? Then you have the axillary artery. The axillary artery, which is the artery of the upper limb coming here, right? It gives a few branches here. It gives the superior thoracic, lateral thoracic, and thoracoacromial, right? So listen to me carefully. Axillary artery, the first part, it gives the superior thoracic artery, and the second part, it gives the lateral thoracic and thoracoacromial. Okay? And they will give you branches towards the upper superior side and towards the lateral side. And then posterior intercostal vessels, they will also give you lateral branches. So I'll just show you this in a diagram. So if this is your, let's say this is where your subclavian artery starts. So this is your subclavian artery. Subclavian artery gives the internal thoracic artery, which will give you medial mammary branches, right? These medial mammary branches will supply the breast. This is the breast, let's say, right? The internal thoracic artery. And these are medial mammary branches. Now this was your subclavian artery. The subclavian artery, it ends at the outer border of the first rib. That's where your axillary artery starts. That's where your axillary artery starts. So I'll take it red. I'll take it from red, and that's your axillary artery. Now, your axillary artery, it is divided by a muscle known as P minor into three parts. First part, second part, and third part, right? The first part gives a branch known as the superior thoracic artery. The superior thoracic artery, it will supply, yes, Pandey, you can definitely get the notes of this lecture. The notes of this lecture will be available on my Telegram channel, that is @Unacademy NEET PG Chetanya, right? These are short notes for anatomy, and I have made them for almost everything that is going to be there, that is going to come in your prof examinations. So stay tuned for that. Yeah, this is my Telegram channel. You can join it and you can get the notes. I'll also try to have the notes uploaded. So maybe I continue here. This was the superior thoracic artery coming from the first part. From the second part, you have the lateral thoracic artery and you have the thoracoacromial artery. Now, the thoracoacromial artery, it gives four branches: acromial, pectoral, clavicular, and deltoid, right? So the pectoral branch of thoracoacromial, it will supply the breast. So like I said, it's coming from the superior thoracic, it's coming from the lateral thoracic, it's coming from the thoracoacromial, and then you have certain posterior intercostal arteries which will also supply it. You will also have supply from the posterior intercostals. So those are the that's about the arterial supply of the breast, right? Now, if I move to the venous drainage, of the breast, the veins first they will converge towards the base of the nipple. So if this is the nipple here, the veins they will all first come from everywhere. They will first converge to the this is the nipple. They will first converge around the base of the nipple and they will form an anastomotic circle. So there's a circle that has been formed, which is a circle of anastomosis. The superficial set of veins they will drain into the internal thoracic vein. Right? And they will also drain into some of the superficial veins of the lower neck. The deep set of veins, they will go to the axillary vein and they will go to the posterior intercostal vein. So where all are they going? The deep set of veins are going to the axillary and posterior intercostal veins. The superficial set of veins, they are going to the internal thoracic veins and to the veins of the neck. Very simply put, that's the blood supply and the venous drainage. So always remember, for your prof examinations, don't ever forget, if blood supply of XYZ is asked, if it is asked, write down the blood supply of thyroid gland. Always remember, you have to divide it into two parts. You have to write the arterial supply separately and you have to write the venous drainage separately. Never forget that. Never forget to write venous drainage whenever blood supply is asked. Okay. So blood supply of breast is an important question. It can also be asked as an MCQ. MCQ is also possible here for NEET PG, and it can also be a long question for your first MBBS prof examinations. Right. Now, when you talk about the breast, what else is there? The breast, do you know its division into quadrants? The breast, it can simply be divided into four quadrants: the upper medial, the lower lateral, and the upper lateral. The upper lateral quadrant, it extends into the axilla, all right, and that there's a foramen here known as the foramen of Langer, and through that there is some part of the breast that extends here known as the axillary tail of Spence. That's one of the first few things that you will ratify whenever you are reading breast. Okay, so that's about it. And the extent of the breast, whenever you talk about the vertical extent, you will write second rib to sixth rib, and the horizontal extent is from the mid axillary line to the lateral border of the sternum. The extent is fairly easy to remember: second to sixth rib, and from mid axillary line to the lateral border of the sternum to the mid axillary line. So the extent is very simple. The blood supply is very simple. Besides that, if you talk about its deep relations, so what is there behind the breast? The breast is in the superficial fascia. So what is above the breast? Skin. What is behind the breast? You will come across few muscles, you will come across a few fascia. So if this is the breast, first thing that you will encounter is something known as retromammary space. What is retromammary space? Retromammary space comprises of loose areolar tissue. And it basically makes the breast mobile. The female breast is mobile. It's even the if it's a case of gynecomastia, then also the breast will be mobile, and it moves over the retromammary space. Why? Because there is a layer of loose areolar tissue which allows the breast to slide over it. Okay. Beneath that, you have deep fascia, which is fixed, and that deep fascia is called as pectoral fascia, which is surrounding which muscles? Pectoralis major, serratus anterior, and you will also have some part of the external oblique muscle of the abdomen. So these are the three muscles that you will find deep to the pectoral fascia: the pectoralis major mainly, then serratus anterior and external oblique muscle of the abdomen. These are the deep relations of the breast. Okay. So now we are moving to the important part, that is the lymphatic drainage of the breast. We'll follow it up with the lymph nodes, the lymphatic vessels. We'll also talk a little bit about the structure overall and the nerve supply. Let's continue. Okay. So allow me to drink water while you just have a look at this particular page and absorb whatever is written here. Try to read it. Okay. If you have any doubts so far, you can let me know. If you have any doubts, guys. Okay. So come here, have a look at the lymphatic drainage of the breast. Whenever you talk about the lymphatic drainage of the breast, you have to remember that there are three primary kinds of lymph nodes that are going to be draining the breast. So look here, the lymphatic drainage of the breast. Let's take a diagram only. So if I look at this diagram, I can divide the breast into medial side and a lateral side. So most of the lymph that goes from the lateral side, it goes to the axillary lymph node. It goes to the axillary lymph nodes, right? That's the first thing that you have to remember. And most of the lymph that goes from the medial side, right, goes to the internal thoracic lymph nodes or the parasternal lymph nodes. And some of the lymph from the lateral side, it will also go to posterior intercostal lymph nodes. So these are the basically three kinds of lymph nodes that surround the three groups of lymph nodes that will surround the breast and they will supply the breast, out of which the main lymph node here is the axillary set of lymph nodes. The main lymph nodes are the axillary lymph nodes. They will drain 75% of the lymph of the breast. 75% of the lymph of the breast. 20% will be drained by parasternal lymph nodes and 5% will be drained by the posterior intercostal lymph nodes. Okay, this is the first thing. Second thing, I'll again take a screen. The lymphatics of the breast, they are divided into two. They're divided into two. They're divided into superficial lymphatics and they are divided into deep lymphatics. Superficial lymphatics and deep lymphatics. Superficial lymphatics includes everything. So first we'll talk a little bit about the structure of the breast. The breast, it is mainly made up of three parts. It is mainly made up of three parts. The skin of the breast, the parenchyma of the breast, that is the mammary gland, and the stroma of the breast. The stroma of the breast is basically fibrous, right? It's basically the fibrous. There are septa called as suspensory ligaments of Cooper, right? The parenchyma is the tubuloalveolar compound tubuloalveolar part which lacks a capsule. There is no capsule in the breast gland, alright? The thyroid and prostate, they have capsules, but remember, the breast, it does not have capsule. Thyroid, prostate glands, they have capsules. They are capsulated glands. whereas the breast, it does not have any capsule at all. It's basically a modified sweat gland. Remember this. This is also sometimes asked. It is a modified sweat gland. Okay, the modified sweat gland. Okay. Now, combined tubular alveolar, no capsule. The parenchyma is the glandular part, stroma is the fibrous part, and the skin is the part that is superficial. The skin is the part that is superficial. Alright. And the skin, what are the main features on the skin? There are two main features. One is the nipple. Nipple, I told you, is in the fourth intercostal space. It is just below the center of the breast and it is 10 centimeters, located 10 centimeters away from the midline, medial to the mid-clavicular line. Then there are some things known as tubercles of Montgomery. These are basically raised and enlarged sebaceous glands at the outer margin of the areola. They are known as tubercles of Montgomery and they are more prominent in pregnant females. Tubercles of Montgomery. Besides that, there is no fat that is below the areola. That's one point that you can remember. That there is no fat that is present subjacent to the areola. Right? So now I was telling you the lymphatic vessels. They are present as superficial lymphatics and deep lymphatics. The entire skin except the areola and the nipple are included in superficial lymphatics and they drain radially. Superficial lymphatics, they drain radially. That is, they drain like this. This is how superficial lymphatics are going to drain radially. Okay. Now, what about the deep lymphatics? Deep lymphatics are the lymphatics of the parenchyma. Plus, they will also include the region of the nipple and the areola. They will also include the region of the nipple and the areola. That's about the deep lymphatics. Besides that, we talked about the lymph nodes. I told you the axillary lymph nodes. Mainly here, the anterior lymph nodes, anterior axillary lymph nodes will be involved. Parasternal, you will have the anterior thoracic lymph nodes. They are called as the anterior thoracic lymph nodes along the internal thoracic artery and internal thoracic vein. Besides that, you will have certain other lymph nodes, the posterior intercostal, supraclavicular, cephalic, subdiaphragmatic, subperitoneal, blah, blah, blah. Lots of lymph nodes, mainly axillary and parasternal. Besides that, you can also remember posterior intercostal lymph nodes. Okay? It also goes to supraclavicular lymph nodes, also goes to cephalic lymph nodes, also goes to subdiaphragmatic lymph nodes. That is not our area of concern right now. Okay. So first of all, we're going to talk a little bit about the lymph nodes that are there in the breast for the axillary region. So the axillary region, you have the folds of the axilla. If I make the folds of the axilla, this is the anterior axillary fold. This is the posterior axillary fold, right? That is somewhat how you will make the axilla. This is your, let's say, I take a black screen. If this is our person, let's say that's how we have made him. So you will make a axillary fold like this, right? This is an anterior axillary fold. If you abduct your arm like this, you will be able to really appreciate what are the anterior and the posterior axillary folds. Right now, I am just showing you in a diagram, but if you do it on yourself, you will be able to identify which are the anterior and posterior axillary folds. So along the anterior axillary folds, you have the anterior group of lymph nodes. You have the anterior group of axillary lymph nodes. They are also called as pectoral lymph nodes. They are also called as pectoral lymph nodes. They are the main lymph nodes of the axillary group. Posteriorly, you will have the posterior axillary lymph nodes. There you will have the posterior axillary lymph nodes. At the junction of the anterior and posterior axillary folds, you will have the central axillary lymph nodes. You will have the central axillary lymph nodes. Alright, so you have the, I've told you about the lateral, or they're also known as the humeral group of axillary lymph nodes. You have the anterior ones, which are known as the pectoral group of anterior axillary lymph nodes. You have the posterior ones, which are known as subscapular, because the posterior fold includes the subscapularis, right? The lateral, I've told you, is the humeral ones. They're along the humerus. And then you will have what? You will have the central group of lymph nodes, which are along the junctions of the folds. And besides that, you have the supraclavicular lymph nodes, which come above the clavicle. You will have subclavian lymph nodes, which are around the subclavian. And you have the parasternal lymph nodes I told you about, right? So these are the group of lymph nodes that are going to be present when you talk about the lymph drainage of the axilla. ठीक है, मोटा मोटा try to remember axillary, anterior thoracic and posterior intercostal, right? Axillary mostly anterior and they're closely related to the axillary tail of span. 75% goes to them, 20% goes to anterior thoracic, 5% goes to posterior intercostal. ठीक है, so the lymphatics, they go to the anterior axillary lymph nodes and to the posterior and apical lymph nodes. They go to the central and lateral lymph nodes. Central and lateral go to the apical and apical go to supraclavicular. So let's summarize this in a slide so that you don't have any confusion. So what are the 5 groups of axillary lymph nodes? If I talk about the axillary lymph nodes, what all have we talked about? We've talked about anterior. We've talked about, these are also called as pectoral. Then we said posterior, these are also called as subscapular. Then we said central, right? Besides central, what did we say? Lateral, or they're also called as humeral. And we said apical. And we said apical, right? These are the 5 groups of axillary lymph nodes, right? Now, one more thing, what happens? The anterior and the posterior, they receive some drainage. They take it to the central and lateral. They take it to the central and lateral. And from the central and lateral, it goes to the apical. From the apical, it goes above the clavicle to the supraclavicular lymph nodes. From there, it will go to the main lymphatic trunks, right? So that is how the flow of lymph goes. That's what we are talking about here. Anterior, posterior, then to central and lateral, then to apical, then to supraclavicular. Okay. So one more thing is there that you have to know is that the anterior thoracic lymph nodes, they will drain lymph from both the inner and the outer half. What does that mean? There is a contralateral drainage when you talk about the lymphatic drainage of the breast. If this is one breast and this is one breast. So let's say this is the sternum. Let's say this is the sternum. Along the sternum, you have certain lymph nodes. You have a chain of lymph nodes like this. These are the parasternal lymph nodes. These are the parasternal lymph nodes. Basically, what happens is there is also a contralateral flow of lymph here. There's a contralateral flow of lymph. What do I mean by that? From here, lymph will go to these ones, and this lymph, it will also cross to the other side. Okay, this lymph will also cross to the other side. How is that? Okay, so the lymph nodes, they receive a supply from both sides. So that is why metastasis is possible to the contralateral breast. That is why the lymphatics of the contralateral breast, they are connected. The lymphatics of the contralateral breast, they are connected. That's one thing that you have to remember when you talk about clinical anatomy. We'll also talk about this point, but you have to remember that the lymphatics of contralateral breasts are connected, right? So the lymphatics go both ipsilaterally and contralaterally. Then there's one more thing. There's a subareolar lymph plexus of Sapi. There's a subareolar lymphatic plexus of Sapi, which is located deep to the areola and it drains to the anterior axillary group of lymph nodes. Not very significant. SM Abbas, what I am teaching is not given in NCRT. I'm not teaching for NEET UG. So for NEET UG, you need to remain restricted for NCRT. For when you talk about NEET PG, the syllabus is not well bound and it is definitely not restricted to NCRT, right? So, I mean, this class is not for NEET UG. If you're watching it for NEET UG, please you can pick this class, right? Okay. So next, let's talk about we've talked about the lymphatics. The deep lymphatics, they pass through the P major and clavipectoral fascia to reach the apical nodes and also to anterior thoracic nodes. And from the lower and inner quadrants, they also communicate. This is an important clinical point, that from the lower and inner quadrants, they also communicate with the subdiaphragmatic and the subperitoneal lymph nodes. They also communicate with the subdiaphragmatic, and subperitoneal lymph nodes. So they will also go to the anterior abdominal wall. They will also go to the anterior abdominal wall. Alright? They'll also go to the anterior abdominal wall. The anterior and the central group of lymph nodes, they are commonly involved in carcinoma of the breast, which is also commonly involving the upper and outer quadrant. So one question that may be asked to you, it's okay, Samavas, that's no worries, it's okay. One question that may be asked to you, what is the quadrant of the breast that is most commonly involved in carcinoma of the breast? The most commonly involved quadrant would be the upper and outer quadrant. Most commonly involved would be upper and outer quadrant of the breast. Most commonly involved lymph nodes, apical and central group of lymph nodes. They are the anterior and central lymph nodes. They are the most commonly involved in a carcinoma of the breast. Yeah. Then there are some interpectoral lymph nodes known as Rotus nodes, not very important. Now I've come to clinical anatomy. of the breast. We are done with the theoretical part of the breast. Now we are going to focus somewhat on the clinical parts. We'll talk about the major muscles, then we'll talk about the clavipectoral fascia, and then we'll end the class. Okay? So let's try to end the class by 7:15. That will be around a 1 hour 15 minutes class. Should be a decent amount of time. So do you guys have any doubts so far? Anybody of you has any doubts so far? You can let me know. The clinical anatomy, I'm not going into as much detail as I have taught it to you. There was a class known as A to Z clinical anatomy of the breast. A to Z clinical anatomy of the breast. It was there on Unacademy. It is there on my profile on Unacademy. You can go and check it out. Go follow me on Unacademy. Alright. Download the Unacademy learning app, and when you buy a free plan there, do use my referral code for any plan that you purchase. It will ask you a referral code, but just write Chetanya 10 there. That's all you have to do, and that will allow you to buy any plan that you want. Okay. Chetanya 10 is the referral code that you have to use while purchasing any plan. If you have any doubts, you can let me know. You can ask me in the chat as well. Okay. The first lymph node draining the tumor bearing area, it's called as the sentinel lymph node. That's the first clinical anatomy point that you have to know. Sentinel basically means a guard, alright, or the first person that is going to guard something. So the first lymph node that drains a tumor bearing area is called as the sentinel lymph node. Okay. Second, breast incisions, they are made radially. So if you've made an incision on the breast, you will make it radially. That is along the radial margin. Why is that done? To avoid cutting the lactiferous duct. Alright, so these are the lactiferous ducts running, and you will make a radial incision. So if you make an incision like this, you will be cutting a lot of lactiferous ducts. Otherwise, if you do a radial incision, max to max, you will be damaging only a single lactiferous duct. Alright. The third thing is that cancer cells, they may infiltrate suspensory ligaments, and if that happens, there is fixation of the breast. Fourth things, if there is contraction of these ligaments due to these infiltrations, there will be retraction of skin, or it was called as dimpling or puckering or folding of the skin. Fifth thing, infiltration of lactiferous ducts. If the lactiferous ducts gets infiltrated with cancer cells, the nipple will get retracted. There will be retraction of nipple due to fibrosis of lactiferous duct. Now, obstruction of superficial lymph vessels, that will cause edema, and that edema will cause peau d'orange, right? That is called peau d'orange. It means that the appearance of the breast, it starts to appear like an orange. Okay. So I've told you three things. Please keep those three things in mind. Let me summarize those three things for you. First, obstruction slash infiltration. There is an obstruction or infiltration of the suspensory ligaments of Cooper. Second thing is there's an obstruction of the superficial lymphatics. And the third thing is there's an obstruction or infiltration of lactiferous ducts. Obstruction of suspensory ligaments of Cooper, what will it cause? It causes fixation of the breast. It causes fixation of the breast and also dimpling of skin. It also causes dimpling of skin. Obstruction of superficial lymphatics, what will it cause? Obstruction of lactiferous ducts, what will it cause? Obstruction of lactiferous ducts will cause retraction of nipple. And this will cause edema called as peau d'orange, right? Which is peau d'orange. Peau d'orange. You can pronounce it in a different way if you want, but it's a French word. So it's basically orange-like appearance. It basically means orange-like appearance. I also have a photograph in the lecture I prepared for clinical anatomy, right? So I told you that the superficial lymphatics, they communicate across the midline. So cancer may spread from one breast to another. That's another point that you keep in mind. Besides that, lymph vessels communicate with the abdomen. So cancer cells may spread to the liver or drop into the pelvis. If they drop into the pelvis, that is known as a tumor of the ovary known as Krukenberg's tumor. There is a tumor known as Krukenberg's tumor. It's basically due to metastasis of the breast tumor to the ovary, right? That is known as Krukenberg's tumor. Okay? It can be an MCQ for your clinical anatomy in next 2022. Okay? Cancer may spread through segmental veins also. Okay, veins draining the breast, they communicate with the vertebral venous plexus. So the cancer can basically go anywhere. If you think about it, it can go into the ovary, it can go to the opposite breast, it can go to the brain, it can go to the vertebra, it can go to all the surrounding structures, it can even go to structures which are far away, right? So carcinoma, it usually arises from the epithelium, right? Most of them are glandular carcinomas. Then there's one thing known as FNAC. You will hear it very frequently, FNAC. It's called as fine needle aspiration cytology. What you do, you pass a needle and you take out some of the cells and you examine those cells to detect breast cancer. It is very safe and it is used to diagnose lesions or breast cancers to make prognosis as well. Okay? So cancer of breast is one of the most common cancers in females of all ages, and it is more frequent in post-menopausal females because they lack estrogen. So estrogen receptors, ER alpha, etc., have been correlated with an increased incidence of breast cancer. So it is more frequent in post-menopausal women due to lack of estrogen. All right, you can keep that in mind. So now we are going to talk about three very important muscles of the pectoral region. We are done with the breast, right? So if you want more detail on the clinical anatomy of the breast, you can watch my lecture on A to Z anatomy of the breast, right? It's a very beautifully done lecture. Uh, my Unacademy profile, you can go to it, unacademy.com. If you're on the desktop, at the rate Chetanya Mittal 35 4586. That's my Unacademy profile, right? Go and visit this. Okay. Now I'm going to move on to the muscles of the region. I'm going to talk about the muscles of the pectoral region. We're about to, so we finished the entire breast almost in 1 hour, in less than 1 hour, in 50 minutes. Now, there's nothing else that you need to read for breast. So, let me remind you all that we have covered today. This will almost cover one chapter of your BDC, right? So, we are covering one chapter of your BDC in around 1 hour 15 minutes, right? So, one chapter of BDC, that's a very decent speed for one chapter of BDC. Even if you're doing it for the first time, you will be able to remember it entirely. And if you watch this video on 1.5x, you will even cover it in 45 minutes. Okay. If you have any doubts so far, you can ask them. Okay, let's go ahead. Right. So what are the main muscles? The first muscle is the pectoralis major. It's a very important muscle. You have to remember not just its nerve supply and actions. Try to remember its origin and insertion as well. Okay, because it's the first muscle you study. It can be asked, especially in your midterms. Origin and insertion of this muscle is important. Besides that, pectoralis minor, you should know the insertion because it's asked in osteology. It inserts onto the coracoid process of the scapula. It inserts onto the coracoid process of scapula. There's a muscle called as subclavius. Again, you need not know much about it. We'll talk a little bit about their main nerve supplies and their actions. So let's just talk here. So the pectoralis minor muscle, it is pierced by a single nerve, and that nerve is the medial pectoral nerve. Right? It is pierced by a single nerve, and that is known as the medial pectoral nerve. So remember, the pectoralis minor, it is supplied solely by a single nerve. It's given wrong in your BD Jurasia that it's supplied by two nerves. It is only supplied by the medial pectoral nerve. The pectoralis major, it is pierced by medial pectoral as well as lateral pectoral nerve, right? So it is supplied by both medial pectoral and the lateral pectoral nerves. See, the P major is a bigger muscle, so it requires two nerves. The P minor is a smaller muscle, it requires only one nerve. P minor is supplied by medial pectoral and P major is supplied by both medial and lateral pectorals. What is the muscle that is pierced by medial pectoral? You will go ahead with P minor. Very important. The question can be asked as an MCQ. What is the nerve piercing the pectoralis minor muscle? Your answer should be medial pectoral without any doubts, right? Subclavius is supplied by the nerve to subclavius, which arises from the upper trunk of the brachial plexus. It arises from the upper trunk of the brachial plexus. What are the actions? Actions of pectoralis major, very important. As a whole, it is responsible for adduction of the arm and medial rotation of the shoulder. It having its insertion here. So when it contracts, it will medially rotate the shoulder. It will medially rotate your arm like this, right? And since it is present here, it will also adduct the arm. It will adduct the arm. If you talk about the clavicular part, it is responsible. If the clavicular part contracts, there will be flexion of the arm. And if the sternocostal part contracts, that's the lower part, that's here, right? The sternocostal part, that will cause extension of the flexed arm against resistance, right? So that's about this. P minor, it is responsible for bringing the scapula forward along with serratus anterior, and it depresses the point of the shoulder. It depresses this part of the shoulder, right? Subclavius, it is basically responsible for making the clavicle very steady, and it provides some cushioning for the axillary vessels because they pass around the clavicle and the first rib, right? So now we come to clavipectoral fascia. There is only one direct MCQ that should be asked from this. That is, what are the structures piercing the clavipectoral fascia? It's a very important question. It can also be asked as an enumerate. Yeah, so the structures that are piercing or an enumerate for this, the mnemonic is CLTL. CLTL. Right? That's how I remember it. You can make some other things if you want, but that's very easy to remember if you can just write CLTL. I'll take a screen. Yeah, C is cephalic vein. C is cephalic vein. So there's basically what? There's one vein, there's one nerve, there's one artery, and there are lymphatics. There are lymphatics. So this is the structure here. So what's the name of the nerve? L is for lymphatics only. L is for lymphatics only. They will pierce the clavipectoral fascia. The nerve here is the lateral pectoral nerve. The nerve is the lateral pectoral nerve. It pierces the clavipectoral fascia. So what does the medial pectoral nerve pierce? The medial pectoral nerve pierces the pectoralis minor. What does the lateral pectoral nerve pierce? It pierces the clavipectoral fascia. And T is the artery that is known as thoracoacromial artery. It is known as the thoracoacromial artery. You will see it emerging from the clavipectoral fascia. And then it divides into four branches: A, P, C, D. Acromion, pectoral, clavicular, deltoid. These are the four branches of the artery, that is the thoracoacromial artery. Okay. So that's about the clavipectoral fascia. Those are structures piercing the clavipectoral fascia. It takes its origin here, right? It moves downward and it encloses which muscle? It encloses subclavius. Then it goes down as a single sheath where it is pierced by the four structures. Then it further divides and it splits into two to enclose P minor. It encloses P minor, then it goes down and it merges with the axillary fascia where it is responsible in suspending the floor of the axilla, right? So clavipectoral fascia, it will form the suspensory ligament which keeps the axillary fascia tight and it helps to maintain the floor of the axilla. So keep in mind one other MCQ that can be asked, that I might ask you, is that what are the muscles enclosed by clavipectoral fascia? Okay, so if I ask you this question, which muscles are enclosed by clavipectoral fascia, what would be your answer? Give you a few options. Who's your answer? Which are correct? Which of these options are correct? Which muscles are enclosed by clavipectoral fascia, right? Do you guys have an answer to this? Okay, Dr. Infinity is saying the answer is A, right? So the answer is not just A, it is also B. It encloses both subclavius and pectoralis minor. Two muscles are enclosed by the clavipectoral fascia, and I have ticked both the options. Okay, subclavius and P minor. Both these muscles, they are going to be enclosed by the clavipectoral fascia. These are the two muscles which are enclosed by the clavipectoral fascia, right? You can see this in this diagram. They first enclose the subclavius, goes down, it is pierced by four structures, then it encloses the P minor, goes down, forms the suspensory ligament which keeps the axillary fascia and holds the floor of the axilla, right? This is the one more layer here outside, and it is the pectoral fascia which will be over the pectoral major. This is known as the pectoral fascia. The clavipectoral fascia, this is the pectoral fascia, this is the P major, this is the P minor, this is the subclavius, this is the axillary fascia, this is the suspensory ligament formed by the clavipectoral fascia, and this is the breast present in front of the pectoral fascia. In between you will have the retromammary space which allows the mobility of the breast. So these are all the structures that you will find here, and these are all the structures that are in certain relations here. Okay. So after that, we are going to talk about serratus anterior, right? We are going to talk about serratus anterior. Serratus anterior, it is also called as the boxer's muscle, or it is also called as swimmer's muscle. You can keep that in mind. So boxer's muscle really helps me to remember the action of serratus anterior. Why? Because what does a boxer do? A boxer does this, right? So what is this action? This action is, you can see that this action, what is this movement, right? These are the actions. It pulls the scapula forward around the chest wall. It protects the upper limb, right? So pushing and punching, pushing and punching. In that, you will be protracting the upper limb. The scapula moves forward along the lateral wall. The scapula, it moves forward along the lateral wall, right? So this scapula is moving forward. That is known as protraction of the scapula, protraction of the upper limb. And that, if you remember boxer's muscle, you can easily remember pushing and punching, right? Then there are some fibers of the serratus anterior which are inserted into the inferior angle. We'll just talk about those. Serratus anterior, it has its origin. It has 8 digitations which come from the upper 8 ribs in the mid-axillary plane. The first digitation is in the posterior triangle of the neck, arising from the outer border of first rib, and it forms a rough impression of the second rib as well. The 5th to 8th digitations interdigitate with the costal origin of external oblique muscle of abdomen, right? Now, what about the insertion? It passes backward around the chest wall to insert into the costal surface of the medial border of the scapula, right? It inserts onto the costal surface of the scapula. That's very important to remember. Okay. Nerve supply is by the long thoracic nerve, also called as the nerve of Bell. Sorry, not the nerve of Bell. It is also known as the nerve of Binging, basically, right? So what happens? Its root value is C5, C6, C7, right? Its root value is C5, C6, C7. It's also known as the nerve of Bell. I was right. It is known as the long respiratory nerve of Bell. It's the long thoracic nerve. Root value is C5, C6, and C7. The first two interdigitations are supplied by C5. Third and fourth are supplied by C6, and fifth to eighth are supplied by C7. It is coming from the brachial plexus and it enters through the axilla to reach the medial wall of the axilla to supply it. So I've told you one action is protraction. This is the most important one. Then second action is also very important because the fibers which are inserted into the inferior angle, they will pull it forward and they will rotate the glenoid cavity upwards. So this is the glenoid cavity here, and they pull the inferior angle downwards. So if this is the, let's say I make the scapula, this is the glenoid cavity, and this is the inferior angle of the scapula. This is the glenoid cavity. So what they will do is they will pull this downward, they will pull downward, and this glenoid cavity, it will rotate upward. Glenoid cavity will rotate upward. So that's one important action where the serratus anterior is involved. So it helps the trapezius in overhead abduction. This action will help in overhead abduction of the arm. So abduction from 0 to 15 degrees is carried out by supraspinatus. 15 degrees to 19 degrees is carried out by deltoid, which is the main abductor here. The 90 degree to 180 degree is carried out by what muscles? Trapezius and serratus anterior. Trapezius plus serratus anterior. Both of these muscles, they will participate together and they will carry out this abduction. It also steadies the scapula and it helps in forced inspiration. Also helps in forced inspiration. So guys, I have one small request for you. If you guys like this video, please press the like button. I would really appreciate that if you can. Just press the like button of this video, and thank you so much if you do that for me. I would really appreciate that from your end. Now, winging of scapula, paralysis of the serratus anterior, inferior angle, and the medial border, they become prominent. So if the serratus anterior, it becomes paralyzed, what happens? It's visibly very apparent that the inferior angle and the medial border of the scapula, they become prominent from the back, and the person is unable to push, and the person is also unable to raise the arm, because these were the two main actions. The one action was pushing and pulling, pushing and punching, and the second action was overhead abduction. So both of these actions, they become difficult, and if you try to do these, the winging of the scapula will become more prominent. Yeah. So protraction, you can see serratus anterior, it is pulling the scapula forward around the medial wall of the axilla, which is formed by the serratus anterior, right? So this is the axilla, you can see this is the anterior border. It is formed by P minor and P major, right? This is the lateral side. Lateral side is made by coracobrachialis and biceps brachii along the humerus. These are the contents of the axilla. You can see the axillary artery and the brachial plexus cords around it. Posteriorly, you will have the subscapularis, you will have the infraspinatus, you will have the scapula. Those will form the posterior border of the axilla, right? So that's it for today's class. If you have any doubts, you guys can let me know in the chat box right now. I'll end the class at 7:15. Thank you so much for watching. And like I said, please, please, please do hit the like button on this video. That will be the least you can do for me if you guys actually like the video or you benefited. And if you learned even a single new thing from it, please do that. And do subscribe to the channel Let's Crack NEET PG, because you will be so amazed at the content that we are making for you guys. Do drop a comment if you can. You can join my Telegram channel at the rate Unacademy. That's the name of our company. NEET PG is the goal that I am teaching for, and Chetanya is my name. So at the rate Unacademy NEET PG Chetanya, you can join this Telegram channel and you can use my plus referral code Chetanya10. Do use this referral code if you plan on taking a subscription, Chetanya10. And if you take a subscription, you will get a straight 10% discount. Besides that, you can also use credits. And if you have any doubts, you can contact me. We also have a discussion group here linked to this channel. You can come there and you can ask your doubts. Mainly, you can ask your doubts about anything that you want. You can have suggestions on what videos we should make. And do hit the bell icon for notifications so that you know that whenever an educator. To give you a little more background on what is happening, what am I planning to do in future, what have I planned in terms of content for you. So just have a look at what I am planning to do further. So I know your MCI profs are coming, MCI nahi, up to NMC. So your profs are coming and they're scheduled for February, right? They're scheduled for February. So what I want to do is throughout December and January, I want you guys to prepare for your profs, especially those of you who are going to start with your revision soon, right? In your colleges. So I am planning to do another video at 7:30 p.m. today. That is in another 15 minutes or so. And we are going to cover urea cycle. So we are going to start with biochemistry there. So we are going to start there with biochemistry. So we are going to do urea cycle. And then throughout December, I'm planning to do a physiology series also for first prof. And like today, I've covered some portion of anatomy. Similarly, I want to keep covering biochemistry and physiology also side by side so that you are prepared to at least pass your prof examinations. Okay? That is going to be our goal. And it's great if you get a distinction there. Chalo, that's it for today's class. If you have any doubts, you can still text me on the channel. And I don't see any doubts here in the chat. So I guess we can end the stream. We'll end the stream in another 5 seconds. Let me just make sure there's no more doubts.